Okay, this is our final portion of hemodynamics, hypertensive crisis, and shock. We are going to talk specifically about two types of shock, cardiogenic shock and hypovolemic shock.
Again, this is something that, for me, basic nurses don't need to understand what are the different stages of shock. I'm not going to ask you a question about that.
Again, NCLEX is built and geared towards basic nursing. So really what I think when I'm thinking basic nursing is I have a client maybe in a step down, maybe in a med surg unit, and something goes wrong and I start to see changes in their trends for their vital signs, or they start to become symptomatic. Most of these are still going to revolve around a pump issue or a volume issue. So that's why we talk about cardiogenic shock or hypovolemic shock. They're pretty straightforward. Hypovolemic, basically, what you do have in your vasculature is kind of sludge. So all of the
fluid that would help with a normal homeostasis is probably in the interstitial spaces or in the lungs. Right? If I have some sort of issue with hypovolemic shock, I always want to ask myself, where did that fluid go? Because the first thing that we're going to do for hypovolemic shock, or even a suspected hypovolemic shock, is to give them a fluid bolus. If that does not help fix things, help lower the heart rate, help improve the blood pressure, we've got to look at why. Or basically it's more of the same.
Instead of a lack of volume, what I do have is I have something in the function of my heart, which causes me to have a decrease in cardiac output. So we will look at both of those. All right, so we have the progression of shock, and we do see its initial, compensatory, progressive, or irreversible. If I'm a stellar nurse, I'm going to catch it here. If I'm an okay nurse, I'm going to catch it here. If I'm somebody who didn't study for the cardiac exam, there we go. Don't get to that point. Once it's at that point, there's not a whole lot that we can do for a client to kind of restart up where they need to be in relation to cardiac output. So cardiogenic shock, first kind of foray into this. I have talked about this to my students, kind of every class period. I'm sure my students this semester will hear me talk about. Basically, the things with cardio, they just circle the wagons. Once you start having this cascade of event happening, that's when you are at most risk for developing this example, or the muscle, because it's the heart, that is no longer able to participate in cardiac output. So it becomes fibrous, it becomes scarred, it's an ineffective pump. If you have changes generally related to heart failure, you may end up in that acute decompensated heart failure. You may have cardiomyopathies. You can have histories of, your itises, myocarditis, pericarditis. But again, that's still a change in the structure and the function of the heart, and that's still an issue with either volume or pump. In this particular instance, it's the pump because it's cardiogenic. So we know that when we're looking at our clients, I've said it doesn't matter their age, that tachycardia is one of the most, it's one of the first things that we can see change for a client who is admitted to us. The problem is that a lot of times that may go unrecognized by the client. That this is how they've always been. I'm getting older. I just climbed 2 flights of stairs. We should be kind of short of breath, but we kind of ignore it because the compensatory mechanisms are working. What shock is that once we have gotten into that initial phase of shock, those compensatory mechanisms are now failing. So we are no longer able to maintain perfusion like we once could. So look for early signs and symptoms, tachycardia, tachypnea. If it's some other unrelated comorbidity, look at the vital signs, look at their trends. Anytime you have extreme blood pressures, either hyper or hypo, you are at increased risk for developing shock. We're going to use a lot of medications to help prevent or treat shock. We'll kind of look at those medications and I'll tell you which ones are important to me. And again, we just see it's so important that you as the nurse recognize early changes in that client's vital signs. It's no different than if I were trying to get a stroke workup on somebody because they've had a change in LOC. I'm having changes here in my vital signs and I need to kind of figure out what's going on. The animation up here, get it going again, maybe. So the animation up here in the right, you can kind of see blood flow from the heart. And again, with shock, you still want to kind of think about where fluid might back up to. Because if I have an ineffective pump, that fluid is not helping with cardiac output, and it's probably going to end up in your lungs or your circulatory system. Right. We know how important pulse oximetry is. You need to be on continuous pulse oximetry because you're a critically ill client. And again, we've talked about our normal is 95. Now, here's the it depends, right? If I know you have shock, I'm not concerned right away if I can't get your SpO2s to 95. But I'm talking about from 90 to 95. Or if you have COPD, 88 to 95, whatever it may be. Without any other underlying issue, so I don't know that you're going into shock, I suspect you're going into shock, whatever it may be. What I would expect is that you're gradually going to see a change in that respiratory rate, and you're going to probably see a decline in the SpO2s. Once we have started to see those changes, and the client is hypotensive, can't maintain cardiac output, their SpO2 is low, maybe the respiratory rate is really fast, we need to start thinking about intubation. But you're probably going to look at your ABGs before we decide there. Again, least invasive to most invasive. This client may end up in the ICU, in which case if they do get intubated, it's no longer a basic client that we would care for basic nursing. Regardless, cardiogenic shock is a life-threatening condition, right? There's certain things that I know that I need to look for to ensure that my client is getting enough O2, enough nutrients, enough cardiac output to not have any serious kind of side effects. So the first thing that I want us to think about, if you see a systolic blood pressure that is below 90 and it's been trending down, I want you to start thinking, is my client going into shock? Do your lung sound assessment, do your LOCs, do your heart rate, your blood pressures, the vital signs, all of that. There are exceptions, right? If the client is perfectly alert and oriented and they're 88 over 55 or whatever, well, their MAP is probably greater than 60, 65, depending on where your doctors want it. So I'm not too worried. I will give you the example of our renal clients, our dialysis clients. They tend to have soft pressures.
especially immediately following dialysis. So we made it give them medications like midodrine to help improve their blood pressure. Obviously, we can do the whole albumin, whatever kind of mix that we want to kind of correct any issues with fluid moving from the vascular spaces to the interstitial spaces. But we know that the big problem here is when those heart cells die, your heart cannot pump effectively. So we care about heart rate, preload, afterload contractility. We care about perfusion. So from our perspective, I'm kind of second guessing anybody who comes in with an acute myocardial assessment or disease process, these acute on chronics, these exacerbations of heart failure, new MIs, new itises, whatever it may be. They're usually most often due to an MI, because that will have a direct effect on your pump. Reduced cardiac output, we've talked about the fact that it's going to lead to issues with your blood pressure, issues with perfusion, and you could end up with some in-organ damage. We've talked about how the compensatory mechanisms are going to work for that, right? I don't care that you understand RAS or catecholamine release or increased vascular resistance, right? What I care about is that you understand that if I have a client and they are trending down, those compensatory mechanisms are beginning to fail. So what you may initially see is a elevated BP and an elevated heart rate. Do this. And then what's going to happen is maybe that BP decides that it's going to go up a little more, but your heart rate starts trending down. What's going to happen then, because cardiac output's heart rate times stroke volume, and that's part of your blood pressure, is that over time, when those compensatory mechanisms fail, both the heart rate and the blood pressure are going to start to trend down. So we're trying to prevent that. We're trying to catch it in the initial stages of shock. And again, generally speaking, most MIs are going to happen probably in your left descending coronary artery, because it's still the left side, and that's probably where that cardiomyopathy, the heart failure, is going to develop. You'll end up with some acute pulmonary edema. So we've talked about the risk factors: acute MIs, heart failures, cardiomyopathies, valvular disease, and again, specifically, it's probably going to relate more to the left side, so the mitral valve. You can have some sort of aortic stenosis. You can have issues with regurgitation. Again, we'll cover those more extensively in valvular heart disease. A history of arrhythmias, obviously ventricular tachycardia, you're going to lose cardiac output. For fibs and bradyarrhythmias, you still lose cardiac output. And then this last one here is, I think we've touched on it briefly in assessment, but cardiac tamponade. So you have fluid accumulating in the pericardial sac, and that's what's going to squeeze the heart. It's going to put pressure on the heart, and that's what tamponade is. So your heart, because of all that fluid that is in there, is no longer able to pump effectively. Complications we've talked about, pretty much the same. You multi-organ dysfunction syndrome, acute kidney injury, pulmonary edema. You can end up with respiratory failure, respiratory distress, issues with liver function. You can end up in an acidotic type of state. And then, of course, if we don't catch them in the first 3 stages, that it could very quickly progress to something that is untreatable.
So basic kind of rules that we want to start looking for is systolic blood pressures that are less than 90. Narrowed pulse pressures. Now, we have said already that narrowed pulse pressures or widened pulse pressures are never good. We've tried to outline why that is, but basically what you need to understand is because those compensatory mechanisms are failing, that there is a huge difference between a blood pressure of 100 over 50 and a blood pressure of 90 over 70. 90 over 70 are narrowed pulse pressures. Right, it should be at least 40, and then you may see them become tachycardic, but again, eventually those compensatory mechanisms are going to fail. Because it's a pump issue, you can have weak pulses, and we've already said that weak and thready pulses is deadly. You can have issues with red, white, or blue, so with our colors, with our temperatures, this is cold, this is clammy, so maybe white. You can have issues with cyanosis, which is our blue, and erythema, which is our red. You're going to see changes in the respiratory pattern and function. Again, listen for pulmonary congestion, crackles. Changes in LOC, new onset confusion. Again, if you hear or see the word new on a test, you know that they're trying to tell you something. Issues with urine output, so either very little or no urine. And then because it's a pump issue and the first place that blood leaves the left ventricle is the coronary arteries, you can have chest pain. Again, we're back to diagnostic testing. And again, nothing changes. I want a full workup. And I'm seriously thinking about changing that in all my PowerPoints. If you come in with any kind of issue that I think is related to cardiovascular, I'm just going to do a full workup. So they're going to be get a 12 lead. We're going to put them on continuous telemetry. I want to get an echo. I'm going to draw some enzymes. I'm going to get a chest x-ray, and then we'll progress from there depending on what the result of these diagnostic testing turns out to be. You are the nurse. You are the biggest diagnostic for that client. All right, and that's why it's important to watch those trends. You can't get caught up in the business of just throwing numbers down because that's what the machine said. Treat the client, not the machine. As far as pharmacology is concerned, so this is kind of where we're going to talk about inotropes and vasopressors. There are a ton out there. Most of them are not basic nursing, but I do want to make sure that I can give medications that I can titrate to maintain your perfusion level. So if you're going to talk about a dopamine or bubotamine or a milurone or any of those other inotropics / vasopressors, we're doing that to restore as much cardiac output as possible. If we do give them fluids, because remember this is cardiogenic shock, you are probably going to also make sure that they have diuretics. We want to try to pull whatever fluid is left in the vasculature back into the interstitial spaces. And then once I've done that, that client may be at risk then for fluid volume overload, which could have a worsening effect over that client's shock. Again, we've talked about monitoring, vital signs, oxygen, I's and O's, positioning, semifowlers, right? Just don't even care, you guys, about semifowlers, high fowlers, low fowlers. It's raise the head of the bed. Basic nursing. Our goal, again, hey, let's restore some cardiac output. Let's make sure that they are perfusing. Monitor their blood pressure while reducing the workload of their heart. How do you reduce the workload of the heart? You cluster care. You avoid stressful situations. We have supplemental oxygen available. So anything that I can do that would cause that heart not to have to stress itself further. We're going to look at preventing organ failure and complications of organ failure. Again, that's going to mostly be with your neuro assessments, your cardiovascular assessments, your renal assessments. And of course, as we have said with everything else, we want to treat the underlying cause, because if I don't treat the underlying cause, they're going to go right back into shock. So here, from my perspective, I'm going to tell you what I think and what I expect you to know. So, dobutamine, right, is going to help increase that client's ability to perfuse. That would be a good medication of choice, and that is a positive inotropic medication. Milrinone is more like critical care, ED, ACLS, so I won't have a question about that on the exam. Again, this is just I want you familiar with it. Your vasopressors, right? Obviously, we're going to use those to increase blood pressure. Are norepinephrine, dopamine, and epinephrine. Those are your catecholamines. So we've talked about that word catecholamines. I said you don't really need to understand what it is, but here are some medications. And from what I would expect, you would get something like this. The client has been prescribed dobutamine for a client with cardiogenic shock. How does the client, or how does the nurse know that the therapy has been effective? It's still going to be just heart rate and blood pressure. For all of these, just like we would expect to give some kind of diuretics if we did have some acute pulmonary edema. Now, you have to bear with me on this one because this is a hard concept to understand. Vasodilators, which directly contradicts our vasopressors. Why would I want to use a vasodilator? Well, I would want to reduce that client's afterload. So you remember we talked about the fact that we wanted to decrease the workload. A thing that increases the workload of the heart is an elevated blood pressure. So if we're starting to see where we're in those initial kind of stages of shock, we want to try to get that under control. And then, of course, we're going to think about aspirin, heparin, and clopidogrel. Aspirin and clopidogrel are our antiplatelet medications. We can give them at the same time. We often do give them at the same time because they work differently. And then you have your unfractionated heparin. You could consider like an enoxaparin or something. It just depends on what else the client has going on. How do I evaluate it? Signs and symptoms. All right, I see improved blood pressure. I see improved cardiac output, increased urine output. I see no changes, or I don't have any issues with pulmonary edema. So whatever we did for the pulmonary edema worked. One of the things I always like to ask you guys, and this is probably already in a different video, because, you know, instructors like to repeat information, is that I always ask the clients, if you could treat one thing, would you treat the pulmonary edema or the cardiac output? Which would you treat? And because we're so used to, oh my gosh, it's pulmonary edema. But I want you to think about how NCLEX works. If I could treat one thing and walk away, would treating this potentially fix this? And the answer is yes. And I did say potentially because, you know, everything in cardiovascular depends. But what I do also realize is that if I treat this, this does not improve. If I walk away from this client just treating the pulmonary edema, they're going to end up with more pulmonary edema because I did not treat the underlying cause. So improved mental status changes, stable rhythm strips, obviously no indications or no acute changes in that rhythm strip. If we think that this is something that has been brought on because the client has had a myocardial infarction, part of what we talk about with MIs is sending them to the cath lab. We're going to do that as soon as possible. Now, of course, there's always the risk of that reperfusion dysrhythmia, but it's more important that we restore cardiac output, we restore blood flow. There are a myriad of ways we can do that: thrombolytics, angioplasties, stenting or not stenting, emergency revascularizations. We're talking about a CABG there, coronary artery bypass graft. If it's because of an aortic stenosis or some sort of regurgitation, we could consider a valve replacement. Again, we just want to make sure that this client is able to maintain their cardiac output. So, cardiac output summarily means make sure you're assessing their vital signs, make sure that you are titrating medications appropriately, and make sure that you're assessing your client for effective cardiac output. Hypovolemic shock obviously occurs when you have changes in the intravascular fluid. So we are leaking, basically, blood, mostly plasma, extracellular fluid. That loss of those components is going to cause that blood to become thick and viscous, which is going to reduce cardiac output, which obviously leads to the shock. It's simply a volume loss. Where did the volume come from? Well, in this case, are they having an issue with hemorrhage? So we can check their CBC. We can look at volume status, right? We can make sure that the client is having adequate I's and O's, that we're administering fluid, and we're monitoring that effectively. This is still a process of shock. So just remember, it doesn't really matter. The only thing that we're differentiating from cardiogenic shock is that this is a volume issue, right? So that loss has had to go somewhere, or it's going to cause changes to your blood pressure. Eventually, the compensatory mechanisms are going to fail, and then you could end up with organ hypoxia or target organ damage. Usually, it requires a decrease in intravascular volume of at least 15% of your total volume. It doesn't sound like a whole lot, but you're talking about 500 to 1,000 milliliters of fluid that you are losing to help with cardiac output. So if I go from 4 liters a minute to 3 liters a minute for the cardiac output, obviously I'm not perfusing as effectively as I should. You can also have issues with changes in your electrolytes, specifically hypernatremia, right? So all of that sodium is still left out there, and now because of the volume loss, you're going to see elevated numbers. Hypokalemia, which can obviously lead to the big ones. So cramps, muscle weakness, that's a safety, again, nausea, vomiting, and cardiac dysrhythmias. Your first thing is going to replace fluids. You can monitor hemoglobin and hematocrit. Remember that it's a 3-to-1 ratio basically, and again, that's just a tool. It's not an absolute rule, but it will help you with hemoglobin and hematocrit comparisons. So if my hemoglobin is 7, then I expect my hematocrit to be 21, And I would expect that if it's trending down, I'm probably going to give some volume. And usually that's going to be either normal saline, lactated ringers. You can certainly give packed red blood cells, because once it drops below 7, that's what we're supposed to do. So what do I look for? It doesn't really change. I'm looking for issues with hypotension. Systolic blood pressure is less than 90. I expect initially that heart rate is going to be elevated, and the blood pressure would be elevated. And then once they start trending towards shock, that's when you see those changes in the blood pressure. You still see the same signs and symptoms. Really, nothing has changed. Right. That's the only new one, is dry mucous membranes, and that's because of the dehydration. Diagnostic tests are pretty much the same. CBCs, CMPs, check your electrolytes, your lactic acid levels, especially as relates to tissue hypoxia. It's kind of like, again, when you've been exercising and your muscles are sore, they've been screaming for oxygen. And here it's the issue of the hypovolemia that is causing that tissue hypoxia. You can certainly look at the coag studies to see maybe they're bleeding out internally, something like that. And of course, always look at the ABGs. Our job is to restore perfusion. So we're going to do that fluids, mostly. Fluids aren't always going to be able to fix everything wrong, so you could still end up on an inotropic or a vasopressor. That's okay, because we're trying to fix the underlying cause. So for us, we're going to look at our normal. We've talked about our MAPs greater than 60, CVPs 2 to 6. So if I am dry, I expect that CVP number to be low. And it's hard to get lower than 2. But what I'm really kind of looking at is, with that information, the central venous pressure, and I have given you a ton of volume and your CVP is still low, again, we've said you have to examine where that blood is going to. You're going to use the same if they're so critically ill that we have to use a pulmonary artery catheter. We're going to make sure that we're able to maintain their SpO2s, and then we're going to make sure that we are evaluating urine output. So, pharmacology, straightforward. IV fluids, normal saline LR. Remember, the LR does contain a lot of electrolytes. And then if you have issues where you're trying to give blood, if you give it with LR, because of the calcium in the blood, it's going to just clot up everything, and you're going to have some really bad complications. We can think about colloids. Albumin is probably the easiest one that most of us know. I tend to give albumin, a few times a year. I'm sure they give it a lot more in the ICU settings. There are a couple other colloids out there. It's something like head of starch, things like that. But those are more like high speed. You're on the EMS crew or whatever it may be. So I would, for my purposes, we're going to stick with albumin. We've talked about packed red blood cells, FFPs. If there are issues because maybe we're bleeding because we have thrombocytopenia, so we can look at platelets as well. Again, vasopressors after we've tried to restore volume, and again, your inotropic medications as well as your vasopressors. Everything hypovolemic wise just depends. So treat the underlying cause of the hypovolemia. Do they need scoped? Do they need an upper and a lower? Is this something that we can see? Are they bleeding out, in an emergency situation? We want to make sure that they have lots of IV access. So you guys know the whole jive about
2 large bore IVs. And then, of course, because I am going to give them a large amount of volume, I want to make sure that I'm doing my assessments to prevent fluid volume overload. I just want the client stable. I want them to have normal urine output. I want them to have normal LOC. And if there are any issues with acidosis, I want those to be resolved. I want that client back to their baseline. So again, in the treatments and evaluations, nothing really changes. Okay, so putting both of those things together, what we're going to talk about is just looking at your ABCs, airway, breathing, circulation, because shock is an acute changing condition. You must start here. So if there is an acute change, it's ABCs. Then I go on, I'm going to look for changes in LOC. I'm going to do things that are least to most invasive. We're going to look at Maslow's, and then we're going to look at our nursing process. So vital signs, we've talked about narrowed or widened pulse pressures, right? We've talked about blood pressures less than 90, weak and thready pulses, and then of course the less serious stuff, changes in level of consciousness, decreased capillary refill because of the ineffective tissue perfusion. We talked about red, white, and blue for our skin, and decreased urine output, as always. So I found this, again, I like this. It's a useful tool. So if they are in shock, we expect tachycardia, we expect issues with blood pressure. Narrow pulse pressures are an indicator. I expect a decrease in urine output. And again, this is the real nursing number, but we will still use the 30 milliliters per hour rule. You see, we looked at extremities and how they feel, and we talk about being pale or mottled or dusky, cool, diaphoretic, changes in LOC, and changes in their respiratory rate or pattern, especially once you start to hit these really high numbers, because now you're going to throw in respiratory distress, respiratory failure on top of your shock. So, supplemental oxygen. Give them as much oxygen as they need to maintain SpO2s. Think about the oxygen hemoglobin dissociation curve, however you wanted to make sure that that client is perfusing. High flow oxygen, you can do 100% non-rebreather. You can do airvos, you can do CPAPs, BiPAPs, it just depends. But what I do want to make sure is that if I do have any of those changes, especially with the respiratory rate and pattern and the LOC, that I'm probably going to have to intubate that client to prevent those acidotic issues. Again, we've talked about having 2 large bore IV access, if possible, maybe a central line, PIC, subclavian, whatever it may be. If I do have issues with blood pressure, you can place the client flat, so in the supine position with the legs elevated to increase venous return. It's no different than what we're going to do for peripheral venous disorders. So here we kind of see the position that we could put them on. We have the legs elevated and the rest of the body in that kind of supine position to help blood flow return to the heart. You're still going to have them on continuous telemetry, still look at their urine output, all the same old sames. For shock, nutrition is going to be vital for these folks. So we can expect to initiate internal nutrition within the first 24 hours. Again, we're going to have to check their labs. We'll probably add AccuChecks into this kind of situation just so that we can make sure that we're maintaining as much homeostasis as possible.
And again, notice that before we do anything, so before we progress to here, and that's why we say the first 24, is that before I give you any kind of nutrition, I want to make sure that I've replaced any kind of volume. We do know that changes in weight, especially weight gains, are typical because of the third spacing of fluids. So the shifting of fluids from the intravascular to the interstitial spaces. And that's everything that I expect you guys to know for shock. So if you have any questions or concerns, please feel free to reach out to me.